This is Addiction Medicine Journal Club. I'm Dr. Sonya del Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME will be in the show notes. So this week, we are going to be discussing a new rapid induction protocol for extended release injectable buprenorphine. How are you doing, John?
Oh, living the dream. Another nice 14-day stint in the office, 14-hour stint in the office, and now I'm here bright and sunny recording with you.
That's right. Ironically, I've been listening to a excellent podcast by the Curbsiders on sleep. They have an expert on CBT for insomnia. And one of the things she started out with, ironically, was you shouldn't work within a few hours of going to bed. And they admitted that they were recording their podcast at like 11 p.m. So
yeah,
we're not taking that advice. It's unfortunately close to bedtime, but that's okay, man. This is energizing to talk about addiction medicine.
Dude, I'm 40 years old with kids. This is after bedtime.
In our house, we call 9 p.m. geezer midnight. And for our listeners, it is past geezer midnight at this point.
Yeah.
So I didn't really have any news stories I wanted to share, but I just wanted to let our listeners know that we are going to be making our third annual appearance at the Pennsylvania Society of Addiction Medicine Annual Education Day. They call it their Annual Addiction Symposium. We've done it the last 2 years, and we do a talk called Articles That Changed Our Practice. So we present real cases and we talk about what we did and then how the research affected us and what we do now that we kind of know better or things have changed. It's a really fun talk to give. It's fun to think about applying these articles to real cases. And so if anyone wants addiction medicine CME, it's a whole day of CME. It's going to be Saturday, March 7th, and it's online. So you can do it even if you're not in Pennsylvania. So yeah, I think we're both just really looking forward to it.
Yeah. It's always kind of fun. I feel like, as a primary care doc, I feel like a lot of my practice involves like guidelines from like other organizations, right? I feel like that's the one time I get to kind of like really get creative with like application, right? It's like something kind of unique and special. And like you have to go beyond just kind of like a standard treatment for some of our patients, like a pseudo specialist, I guess I would consider myself.
Yeah, well, and it's fun to do this because we're presenting relatively new research, and a lot of what we talk about hasn't really made it into any guideline. It's newer stuff. It's a little bit unclear how one would use it, and the drug supply changes and addiction medicine changes very fast. So it's fun to think about actually using it. I'll put a link in the show notes to the website for the symposium, and hopefully some of you will register for that conference. And then in more conference news, this is in April, I'm going to be going to the ASAM National Conference in San Diego. But John, you will not be joining me, right?
No, I've blown all my CME for the year. Time. And I just was notified today that some of them might be overextended there.
You went a little overboard on CME time.
It's hard, man. It's pay to play a lot of these things, right?
Yeah, it's true. But if anyone is going to go to ASAM, it's in San Diego the week of April 23rd to 26th. I'm presenting a workshop on benzodiazepine tapering. So if anybody plans to come to ASAM, please come to my workshop or just find me to say hi. So with that announcement passed, John, are you ready to talk about our article?
Yeah, this is a really interesting article. It was from JAMA Network Open just from October of 2025. It's rapid versus standard induction to injectable extended release buprenorphine, a randomized controlled clinical trial. And a little bit of background here. So highly potent synthetic opioids, particularly fentanyl and its analogs, are the leading cause of fatal overdose in the United States. It accounted for more than 50,000 deaths in 2024, which is the year prior to this. Despite this public health crisis, there's limited clinical data or trial evidence to guide buprenorphine initiation and retention strategies to patients using fentanyl. And I think that this is something I think both you and I see in practice every day. This really it's felt like a shift in need and how you kind of address initiation and retaining these patients, which is interesting because it's kind of still opioids, but it feels different. I mean, do you agree with that?
Totally. I always had no problem with getting people on buprenorphine with my outpatient induction protocol. And just this last year or two, I've had a bunch of patients it didn't go well for. They had precipitated withdrawal. They couldn't get on the buprenorphine. It just didn't work as well in the face of fentanyl.
Yeah, I feel old. I think I've been doing this for like 8 or 9 years now, and you taught me when I was a younger, more eager physician, and now I feel
bright-eyed and innocent.
We're colleagues, and I feel like I feel like induction has changed, and I'm also fighting with technology more and more. I feel like it's definitely I'm just getting older. Something's changing here, right?
Ooh, if you're already fighting with technology, it could be a problem over there. You got another like 25 years till you can retire.
Too many smart devices. So Sublingual's a once-monthly extended-release subcutaneous buprenorphine injection. It's approved for treatment of moderate to severe opioid use disorder. Extended-release buprenorphine improves opioid abstinence, treatment retention, and health-related quality of life, and is well-tolerated with sustained benefits during long-term use. And there's several studies showing it does have a niche in kind of just standard opioid use disorder. I will tell you, like in my clinical practice, I sometimes use this for salvage as well. And it certainly can be a very effective treatment. The previous initial dosing regimen for this was a kind of this standard 7-day induction with a dose of 16 milligrams prior to kind of lead into it. They've subsequently come in with some updated inserts where that's not necessary, that you can do like a more rapid kind of transition into the depot formulation without that full 7-day lead in. So I think that's been kind of a relatively recent changeover. And there is some pilot data showing that rapid induction with extended release buprenorphine with a single 4 milligram transmucosal dose is safe and well tolerated. There's a thought that with rapid induction, you basically kind of get some of this prelude to treatment out of the way. You get people on a more stable therapeutic buprenorphine blood dose. And also you kind of reduce withdrawal symptoms and overdose risk more quickly. So it's a really kind of favorable idea, or something that seems very interesting to use in clinical practice. So what's the clinical question here? The clinical question is rapid induction for initiating extended release buprenorphine as safe and effective as standard induction in individuals who inject opioids or use fentanyl? So we really wanted to see, does this rapid induction protocol, how does it perform compared to the standard protocol, especially looking at our fentanyl using subtype? A little bit about the study. So the study design, this was a multi-center, open-label, randomized clinical trial conducted at 28 outpatient treatment centers in the U.S. and Canada. And it was between October 26, 2021 and January 19th. It enrolled 729 participants comparing this rapid induction versus standard induction protocol to extended release depot buprenorphine. And they assessed treatment retention, specifically looking at things like percentage of patients that went to their second dose and how they stayed within treatment throughout the protocol. The participants were adults aged 18 and above. They met DSM-5 criteria for moderate to severe opioid use disorder in the past 90 days. They were actively engaging in high-risk opioid use, so either injecting opioids, they had high-dose opioid use, or they used fentanyl. And they had to do it at least 5 days per week, or 5 days or more per week to be enrolled. They were randomized treatment in a 2-to-1 randomization, so more were randomized to the rapid induction versus the standard induction. And they also kind of substratified based upon fentanyl use as assessed via baseline urine drug testing. So here's a little bit about the specific study protocol. So they did a baseline induction assessment. And so they kind of started with a timeline, followed back looking at how much opioid has been consumed or used over the past month, kind of to determine eligibility. They did a baseline urine drug testing. If you were a person of childbearing capacity, you got a baseline pregnancy test. They would do a baseline opioid assessment scale with the cows. They did vital signs, and they did baseline EKGs. The induction protocol puts you into one of two arms. So one was, let's just kind of talk about standard inductions. That's 7 days of the sublingual buprenorphine, followed by your first 300 milligram extended release buprenorphine injection, administered a week later. So you had a 1 week lead in. That's standard. The rapid induction, on the other hand, patients would come in, you got a single 4 milligram sublingual buprenorphine dose, and then you receive your first 300 milligram extended release buprenorphine injection at that visit. So basically rapidly starting the protocol. There was follow-up visits, and they did a subsequent extended release buprenorphine dose That was the depot 300 milligram dose at week 2. They also assessed vital signs, CAL scores, EKG. They did urine drug testing at that visit. They did weekly visits through week 6. Week 6 was the third buprenorphine injection, and they also did vitals, CALs, EKG, and urine drug screen testing at that point in time. So it was kind of a rapid induction protocol, and actually kind of doing the back-to-back loading doses a week apart. That's kind of rapider than the initial protocol, which was kind of doing the monthly. So it was like an ultra-rapid induction protocol, really.
Have you done those 1 week back-to-back 300 milligram doses with anybody?
I've offered it. I haven't had a patient that has wanted it yet. So it's kind of interesting. I just feel like I think a lot of people that like that depot injection, I think they like the spacing of, I get along with them well. I think they just don't want to see me that frequently. But I've offered it to several patients.
I have one person who wanted it and I couldn't get the insurance to cover that second dose. And I had a pro tip from someone which was said, order both doses at the same time. And sometimes you can get both doses delivered. And then you can give that second one when you want. It doesn't have to be in a week. You could wait 4 weeks if the patient doesn't want it.
That's interesting.
I feel like I have people who don't come back after the first dose, though. I don't want to order too much medicine that is never used.
Yeah, I haven't really. I just haven't encountered it. Just this past week, I offered this to someone, and they didn't want to do it. They just want to come back in a month. And I do feel like sometimes, I'll give people a couple of extra strips after that first loading dose in case they need it towards the tail end of that month. But I think they'd rather go that way than hang out with me in a week.
Just see Dr. Keenan all the time.
I do feel like it's like some people I've seen so many times over, 8-9 years. I feel like they do feel family-like.
Yeah, it's true.
Yeah. So methods, in terms of primary outcomes, they looked at treatment retention at extended release buprenorphine at the second injection. So that was the primary outcome. Did they kind of come back in time to do the second injection? So complete the induction series. Secondary outcomes were retention at that third injection. So not only completed the 2 loading doses, but followed up a month later. They looked at time to treatment discontinuation. They looked at retention stratified by urine drug testing results for fentanyl. There were some safety outcomes. They did the opioid withdrawal symptoms at each visit. They looked at LFT changes at each visit. So prior to each injection, you got a LFT panel, EKG changes. So at each injection, vital changes, injection site reaction. And they did basically non-inferiority study looking at their randomization between the 2 groups with a 10% margin of error kind of determined for their statistical significance. Any questions about the methods before I go forward?
Not at all. I am impressed with how many people they got into this randomized controlled trial, though.
Yeah, that's really good. So is the trial valid? The funding for the trial was provided by Indivior. So that's the company that produces Sublocade. They also participated in the study's design, conduct, data management and analysis, manuscript preparation and approval, and the decision to submit for publication. So, not a critique, although this is pretty direct industry funding in terms of this trial. I don't think it gets any more industry funded than this. Dr. LaFolle received grants from Alkermes, Canopy Growth, CAMH, Waypoint, and the University of Toronto, and served as consultant or advisor for several companies. Dr. Dobbins is an Indivior employee with a pending buprenorphine patent, so that's kind of interesting. So strong industry funding there as well. I wonder what the patent is.
I know, right? Some new buprenorphine?
Yeah, I'm curious. It's a large multi-center open-label RCT of 729 adults with opioid use disorder, assessing these kind of 2 stratified treatment arms for depot buprenorphine. This is the good and the bad with an industry-funded study, right? So you don't see a study like this with that has the money behind it to do this with a grant, right? This is a very good study. So large RCT, that requires a lot of funding to produce that. And so not that the industry funding could have affected the results. It's always a possibility, but I think more so in order to do something of that quality, you need money. It's kind of unfortunate the way it is. There is a possible reporting bias because there was no blinding. So I think that's kind of one drawback. I think if they would have done some sham shots there, for people, that might have also made a little bit of a difference. there is a strong placebo effect, and injections particularly have a strong placebo effect. Like we know that as an outlier from other studies about placebo effect. I mean, B12 injections.
The ultimate placebo. Well, it's hard to imagine that. I guess everybody would get both an injection and films, and you wouldn't know which was active and which was placebo because you couldn't leave people without treatment at all.
Exactly. That's what you'd have to do. That'd be kind of cool.
All right. We're on it next time.
I think a big strength of this study is that participants really were kind of like, I like to call like real world condition patients. So when you look at it, I think sometimes when I see these studies, there's a lot of cherry picking for like kind of mono substance use with opioid use disorder. And I don't think that's what most of us see, right? I think polysubstance use, especially stimulants, is something that most of us are seeing day to day in our clinical practice. And when you look at this trial, they did not do that. There was a lot of polysubstance patients. When you look at kind of baseline testing, amphetamine, methamphetamine was almost 70% of patients. So this is very representative of the patient panel I see, at least in my clinical practice, not cherry-picked whatsoever. The authors note that the rapid induction protocol was based on a pilot study using a 4 milligram induction dose, although more recent studies suggest some patients may require higher doses. I mean, I guess if anything, this would really kind of underpower results. So I don't think that this is really biasing us that this study is worth more than what they're saying. The authors also note a substantial initiation barrier related to obtaining baseline liver function testing. I feel like as a primary care doctor, I mean, half of my visits start with, doc, I forgot to get my blood work. I feel like that's like,
Wait, now I'm anxious. Am I supposed to like be getting baseline liver testing before I give anyone an injection of buprenorphine?
I don't.
But I have a checklist that's like recent LFTs, and often it's like pending.
Yeah.
Oh
I
my
haven't.
God.
I know that there is a LFT effect with buprenorphine, although I prescribe a lot of buprenorphine. I haven't seen that. But even my hepatitis people, I'm not seeing these LFT elevations with starting buprenorphine. So all the more power to them.
Yeah, I haven't ever seen it.
Yeah. So that's a barrier to starting if they had to do that, right? So that's a kind of against them. There's also a possible retention bias due to the fact that the medication was provided at no cost, and that it was a stipend and travel reimbursement to participants. So I kind of look at this like a wash, right? It's like a retention and a retention bonus and a barrier to initiation. So I think it kind of works both ways here. I don't really think this goes one way or another if I was a referee. Any other thoughts?
No, it's a pretty simple setup. Like you said, they didn't cherry pick the patients and really limit it. And the treatment's easy to understand, So yeah, I think it was good.
I love that. So a little bit of the results. So demographics. So when you look at, there was a total of 1,434 patients screened for this. Only 785 were randomized that met that inclusion criteria. So basically half of the patients that were screened were actually included in the randomization. 729 were included in the analysis. 474 in the rapid induction, 255 in the standard induction. Give you a little bit about the demographics. Otherwise, mean age of 40.7. That was balanced between the groups. Most were male, 55.7. Most were white, 77.5%. 78.2% were fentanyl positive at induction, and they balanced that between the two arms. And that was actually statistically significant how they were balanced equally. So that's kind of very interesting. The mean lifetime opioid use was 14.7 years. And a near daily opioid use in the prior weeks was 27.8 days out of 28 days. So,
oh my gosh,
this group was using quite a bit. So in terms of primary outcomes, treatment retention was the primary outcome at injection 2. And treatment retention was higher in the rapid induction group versus the standard induction group. So that was a 66.4 versus 54.5%. So there was an 11.8% increased retention in the group with the rapid induction protocol. And that was very highly statistically significant, P less than 0.001. So very, very statistically significant. Secondary outcomes among the fentanyl positive subgroup, rapid induction significantly improved retention at injection 2, 62.8% versus 47.9%. So almost a 50% improvement in retention with the rapid induction in our fentanyl positive subgroup. So even better. That's kind of very surprising and reassuring. Retention through injection 3 favored the rapid induction protocol as well, with a almost 8% improvement, so 58.9% versus 51%. There was no significant retention difference in the fentanyl negative participants, so they were about the same. So it was really almost exclusively or mostly we're seeing this in this fentanyl positive group. And the time to study discontinuation numerically favored, but was not statistically significant for the rapid induction. So, the rapid induction here seemed very effective, favored retention at almost all time points, and actually seemed incredibly more powerful in our fentanyl group, which is classically a more difficult population to treat. In terms of any safety outcomes, so they were similar between the two groups. So the rapid induction versus standard induction, there was a 42.6 versus 36.5% rate of any treatment emergent adverse effect, which is relatively high percentage in my opinion. In terms of severe treatment-related adverse effect, they were uncommon and comparable, 3.6 versus 2.4%. In terms of opioid withdrawal-related events, they were numerically higher in the rapid induction, but not statistically different. I think it's interesting that in both of these groups, so the rapid induction was 31.4%, and the standard induction was 25.1%, that there was that frequency of opioid withdrawal-related effects in both groups. So actually, that's kind of moderately high in my opinion, regardless of which protocol you used.
Right. Either like somewhere between a quarter and a third of people had some withdrawal symptoms when they got the injection.
And it may be mild, but I mean, I think that's pretty high. In terms of
Yeah, it is high. Although I feel like if you're using fentanyl daily, even 7 days on buprenorphine, there's still like some fentanyl in your system,
Injection-related adverse effects were infrequent in both groups, so 4.2 versus 7.9%. One death occurred in the rapid induction arm, but it was not treatment-related. So that's kind of the outcomes there. What did you think of those results?
I mean, I'm not surprised that the rapid induction had better outcomes in terms of treatment retention, just because it got people on the more effective treatment quicker. And I'm not surprised the rapid induction had more withdrawal symptoms, although it wasn't statistically significant. I guess I was surprised, kind of like you, at the high rate of some withdrawal symptoms. But in general, I mean, I think it was great. I actually was a little surprised because I thought that I do worry about precipitated withdrawal, especially people using almost daily fentanyl. And a single dose of buprenorphine is not enough to kind of get all the fentanyl out of your system. So basically, people are kind of accepting some withdrawal and just going for it. That's sort of what it seems like to me.
I also feel like the biggest thing is like pushing through if you get precipitated withdrawal, I feel like, you can abandon induction, but I think it's more so like, let's forge through the tornado here.
Yeah. And we had talked to another doctor who does a lot of injections without any initial sublingual dose, just because of the setup of where the clinic is and, the resources the patients have. And the patients know they're going to have some withdrawal. They prep for it. They get education on it, and they kind of go for it anyway, because they're just willing to take that small amount of withdrawal to get onto the medication.
So interesting. So, the results help me in patient care. It's interesting. I feel like induction has really become quite the challenge anymore with kind of this fentanyl using group. I feel like I really struggle with it. Not only that, patients really fear this. I feel like this is a very common concern. And I have patients all the time that come to me and they really keep coming back, but they haven't even started the medication because they're just so scared of precipitated withdrawal, especially in this fentanyl era. Even with long washout periods, I still see people that develop some degree of withdrawal-related adverse effect with initiation, especially this fentanyl just lingers and lingers and lingers, especially with chronic use. These barriers often lead to avoidance of induction and self-discharge without treatment. So it really ends up being missed opportunities related to either, precipitated withdrawal concerns, the fear of it, or the actual event. In the past, I've kind of used these low-dose buprenorphine inductions, often kind of like nicknamed micro-dosing inductions. I actually find them, while they're very useful on my inpatient side of my practice, they're very difficult outpatient because it really requires a lot of precise direction following by patients, and I feel like it's a lot to ask them. I often think that I think even like docs will curbside me about this and they're confused. So I think it's tough for them. even a very literate, smart person. I think that despite industry funding and limitations, this is a large trial that does support this rapid depot buprenorphine induction as a viable option. I think it would require some shared decision-making with patients, but I think it could be useful in many of these patients that I see that come in and we have week after week visit and they haven't even started the medication yet. And I actually, I don't often read an article and then do something that I read in the article. I mean, I try to be an early adapter, not the first. There's like that bell-shaped curve with you want to be that kind of
right.
Not the person in the beginning, but maybe like a couple steps behind. I actually think this is something I am going to use in my practice. And I have a patient that I'm teeing up to use this. And it's literally a person that they clearly want to be on this medication. They clearly want help. And I have seen them every week for almost 8 weeks. And they are just afraid to start the medication still using, but they come back every week. So they want help. I know they do. And I actually gave them this article to read. And so I'm going to see what where this goes. But it looks like I ordered the Sublocade already and I'm going to try this.
Yeah, actually, I had a similar experience. I have a patient who's very, very scared of starting Sublocade because she's using fentanyl and she's saying, oh, well, I haven't had my 7 days on the sublingual yet. I still use some fentanyl in there. I know I have to be on it 7 days before the shot. I said, no, you do not have to be on it 7 days. As long as you've had a single dose, we can do that shot. Even if you use fentanyl this week, we can do that shot. And so she's coming in tomorrow to get it. Hopefully she'll come. So yeah, I've used this article this week also. Well, that's awesome. Well, John, thank you for presenting this article. And thank you to our listeners. Thank you for listening to the Addiction Medicine Journal Club. The best part of Journal Club is the conversation with your colleagues, and we really want to hear what you have to say. So if you have done these rapid start injections of buprenorphine, if you started it after a single dose, or you do in the future after hearing this podcast, we would love to hear how it went. We want to hear your opinions and any feedback you have for us. So send us your comments, and we're on all the social medias. We have an email. We have a Facebook group. It's been a little quiet recently, but you can join our Facebook group and comment there. There's a bunch of people in there. I'll put the links in the show notes for all that, those ways to communicate with us. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from MyCares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.